Once again, thank you very much for joining me today on this last presentation on pediatric dermatology in ER dermatology emergencies. Today, we are going to talk about further dermatological emergencies, and we'll talk about further things as well. And with regards to the today, what I would we're having a sort of technological issues today, and let's hope we can sort it out. So, with regards to the disclaimer, again, this is a pure academic activity, and myself, our CME team, and my hospital have no financial interest to declare. Now, before we start, I've shared this because of a reason. We have to think outside the box. Most of our knowledge is dependent on previous research, but if we come across something new, we wouldn't know. So there are occasions in medical practice when our knowledge or our do have limitations, and hence we will have to explore new horizons. So this is American desert. And you can see these stones, which obviously you can see they are huge. I haven't shown you the comparison here, but they move. So these stones move without anyone touching them, and they are hundreds of tons each. So people were very much fascinated. Some obviously some other stories, collaterals, ghost stories, so many folklores and things. But what the scientists have done, and then obviously the team there have to involve NASA, that this is a dried salt dried lake. And what happens overnight, the temperatures fall in the desert, and the water is very close to the surface. It freezes. Once it dehydrates in the morning, and it becomes more again watery, that slips through, and hence the rocks move. So the main reason of sharing it here is that we have to think outside the box. What we are coming to discuss today, dermatological emergencies. Unfortunately, some of these we don't know the underlying physiology very much. There is still extensive research that needs to happen. Now, our topics today are erythema multiforme, toxic epidermal necrolysis, Stevens-Johnson syndrome, and staphylococcal scalded skin syndrome. Erythema multiforme, we've already discussed in one of our previous lectures, but it's acute, self-limiting, abrupt onset, fixed red papules which evolve in target-right lesions, mostly on the acral lesions, so on arms and legs, but can happen anywhere else on the body as well. Viral pathology is thought to be the reason. It was first described as typhus annus because it was recurring every year in spring, and that was in 1860. And you can see these are the sort of typical lesions we see on the palms. It is so there is a Bryce criteria, and it's which tells us that it is acute self-limited illness, usually up to a month, sometimes slightly longer, but most commonly under a month. Symmetrical, fixed, discrete, round, red papules. Some of them evolve, some of them don't. Mucosal involvement is absent, or if there is one, then it's only limited to one mucosal surface. And obviously, then the histology goes hand in hand. This is herpes labialis, which resulted in, unfortunately, EM. And you can see the target lesion on the cheek. Now, let me go back to the previous slide. And so here, there is a lot of confusion and discrepancy and overlap. There is a huge gray area: erythema multiforme, minor, major, TEN, and then SJS. Some people think there are different academics. So some people think it's the same spectrum, and hence one is minor, then slightly more involvement, and then obviously severe end of the spectrum. But predominantly, academics suggest that EM is separate pathophysiology as compared to TEN and SJS, and hence today, yeah, I'm following that, and SJS and TEN are grouped separately but grouped together. When we are talking about both of them, we'll interchangeably. We'll talk about them because there's the percentage of the skin involvement which is different, and the outcome is slightly different. But actually, the treatment predominantly is the same for both. While here on EM, we obviously we are talking it through separately. Now, EM specific points, they are fixed lesions, usually at the same skin site, target height appearance. Cobner phenomena may be observed. And, if there is a line of, so that's another thing to remember. Usually episode is few weeks, as I've pathogen causing it. And again, with this sort of academic following, which or the group of academics I follow, EM doesn't progress to SJS. Again, it's a lot of gray area. Americans and British or Europeans have different ideas. So please do follow your local advice and guidance with regards to that. Now, difference between urticaria and erythema multiforme. So urticaria, the central clearing, if there is, the skin is normal. While in the erythema multiforme, the central skin is still dusky, sometimes bullous, or it's damaged skin. In urticaria, the lesions move around, while in erythema multiforme, usually they are fixed, at least for a week. Urticaria can have associated swelling, but EM doesn't have any hand or feet swelling, no angioedema. Urticaria lesions obviously appear daily, while EM lesions appear only in the first few days and then they don't change. Treatment for urticaria, for EM, we say antihistamine, antacids for the oral ulcers, recurrent HSV, then obviously we need to treat that, and up to 12 months of prophylaxis. So don't be shy of giving long-term prophylaxis. Oral steroids, again, practices do differ in different parts of the world. Some people will use it, some people won't. There are no trials that support it. And hence we would suggest not to use oral steroids that it's not indicated. Now we're talking going into the second topic, which is a huge one, and apologies if it gets you a bit more confusing as we go on, because TN and SJS we have grouped them together because of the underlying pathophysiology, and you will see definitions. It's nearly always caused by medications. Who gets it? It's reasonably uncommon, sort of 1 to 2 cases a million of each, and mostly on medication. So drugs are the main reason for this condition, and it's most of them, nearly half of them, are antibiotics, as you can see on the list. So please be cautious for using the antibiotics in patients. Mechanism is still not very much known. And usually there is an upper respiratory tract illness before the whole mechanism starts. Symptoms, so temperature, as all of us are aware, sore throat, upper respiratory tract, so obviously difficulty swallowing, runny nose, cough, conjunctivitis, so typical upper respiratory tract illness. Then the skin, from skin perspective, we have macules initially, which are erythematous, can be purple or purpuric spots, diffuse erythema, and target lesions, just like an EM. And blistering, as you can see on the photograph, is usually flaccid and not dense. Sorry. And with regards to complications, during the acute phase, potentially fatal complications include dehydration, malnutrition, infection, multiple organ involvement, and thromboembolic phenomena. And that is actually, if we stay here and think about the complications, you can see that's what we have to think about when we are treating someone for dehydration, for malnutrition, for infection, for respiratory, gastrointestinal support, multi-organ involvement. So, so actually the complications tell us about what organs or what system supports we have to think about when we are treating the patient. It's not only skin, it's obviously the whole body. Now, the mortality is around 10% for SJS and at least 30% for TN. So remember, we were yesterday talking about other other dermatological emergencies, and around 10% is the rule of thumb for most of these emergencies, the mortality. So it's significantly high. TN is acute bullous cutaneous disease, extensive and similar to SJS, most in the first month or two. Now it differs from SSSS, which is Staphylococcus scarlet skin syndrome. We'll talk about that in the last few slides. And histologically, there is quite obvious differentiation. Mucosal involvement, so mucous membrane involvement is nearly almost always there. So that's the differentiation between EM, where it's very less likely, and DEN, there is very much likely involvement of the mucous membrane. So think about eyes, mucous membrane orally, or groin area as well. And Nikolsky's sign again is the topical skin sign, and that is positive. And you can see here quite in extensive involvement on the skin, erythema, slight skin edema, a little bit of oozing, and you can see it's all over the body. And drugs we have discussed, while there are antibiotics, but you can see anti-epileptics have significant involvement as well. I think we have got a case report, case study, which I'm going to share as well, and that is because of anticonvulsant, or that was actually a mood stabilizer. The prognosis, significant mortality if it is for TN. If it's not treated, the earlier we go in, still the mortality is significantly high. ICU cares involve your intensive care colleagues. Complications, so 1/3 will develop complications. So please bear that in the mind. I remember a patient back in London where a 16-year-old boy developed TN and was transferred to intensive care. Luckily survived, but had so much complications: skin loss, scarring, mental health we have to think about. So that unfortunately that child developed post-traumatic stress, and so many issues. And for lifelong, that child ended up with the eye medications because of the adhesions. So blindness is reported, and nail loss specific to TEN. I think it's again in one of the slides later on as well. And in adults, we have score 10. Unfortunately, there is, as it stands, there is no pediatric validated score for the condition and the prognosis. Now, 10 specific, we have systemic steroids, controversial, but we cannot recommend that. Some people use it. Again, in the intensive care setting, it depends on the intensive care colleagues if they're comfortable in using steroids in this condition. IVIG is used, and its documented doses between 0.2 to 0.75. And remember, sucrose excipient. So the IVIG comes in sucrose-based and non-sucrose-based in excipients. The problem is here renal involvement. So kidney is already hit with the TN. And if we give them sucrose-based IVIG, which is sucrose is used as an excipient, the renal impairment happens. And I've seen a patient back in my training days when that was picked up, and then the patient was switched over to non-sucrose-based IVIG. Now, background, let's talk about a patient, a 16-year-old tennis player, came to A&E, possible drug reaction because they started something, a mood stabilizer, and they were worried about it. And you can see she was sent home, reassured, mild antihistamines, came back to her pediatrician, and they recommended again some other, Benadryl 3 times a day, and was advised to watch out for the red flag symptoms. Unfortunately, I ended up back. Obviously, these are Google stock images. She ended up back in the ER, developing blisters not on the face and lips, but on the chest, and severe lip and mouth sores, admitted to the hospital, and then the temperature, the rash progressed, and she developed a temperature after that. So what, in this scenario, what our differential diagnosis should be? So it's usually Stevens-Johnson's syndrome, transdermal epidermal necrolysis, or TN, viral exanthemes, toxic shock, exfoliative erythroderma, SSSS, or Kawasaki. Kawasaki, it is this patient is 16, so slightly less of a differential here, but still we have to think about it. Baseline investigations were done, and you can see our diagnosis or the clinical diagnosis made was SJS. It is, as we discussed, rare, and there are so many unanswered questions. What is this reaction to? How the drug reacts? Which kind of drug we are talking about? Is it a single drug or multiple drugs? And why some parts of the body is more affected than the others? But we think, as it stands, it's an immune complex mediated hypersensitivity disorder due to medications, viral infection, malignancies, and cell death happens because of this separation of epidermis from the dermis. Now, with this sort of patient, and just like the other patient I discussed, it, that of the male, this patient unfortunately ended up with left or scarring, SGS or TN induced rheumatoid arthritis or juvenile idiopathic arthritis, fingernail loss. That was transient, but vision issues have continued. She need to use lifelong eye drops and under ophthalmology surveillance, just like my other patient. Obviously, we have to worry about our reproductive system adhesions, future fertility. We don't know. Sensitive skin, it's documented. These kids and these patients will have sensitive skin for the rest of their life. Sun protection is almost always advisable for all of us, but for these patients more strictly. Swimming pool because chlorine irritates it, and hot tubs because of the temperature, and sensitive skin is usually not advisable, and caution is dispensed. This is from one of the Japanese professors, some slides I'm sharing, diagnostic criteria for SJS. And obviously you can see the worst end of the spectrum is quite alarming. Now, the major criteria, again, is Japanese Ministry of Health. Every country will have their own, and I'm sharing it because obviously it summarizes in a single go major criteria, minor criteria, and obviously diagnosis. So please do consider these. It actually tells the same thing. Our diagnosis or our diagnostic criteria is more of sort of in the definition way. This is again more in a tick box way. So just think about the diagnostic criteria when you are seeing a patient. And TN, again, it's overlap SGS and TN, and you can see it, it's more than 10% body surface area or less than 10%. So that's the sort of cutoff mostly. And other complications, you can see quite significantly, liver is involved, GI tract, and pneumonia. So these are the most common, but again, renal, as I was mentioning about the excipient in the IVIG, it is a significant proportion of patients with that as well. Chronic, you can see ophthalmic, skin, and respiratory issues, very common. This is Cotan. This is validated for adults, but not for children. I don't use it for children. Obviously, we are dictated by the clinical progression and an MDT input rather than any clinical checklist criteria in pediatrics. I hope at some point we will have Stephen Johnson. This was first diagnosed in 1992 or labeled in 1992 as acute mucocutaneous syndrome in 2 boys. Initially, as I've mentioned previously, mislabeled as EM major. So there is no EM major, EM minor. That's the reason we don't follow it anymore. It's uncommon, and obviously this peak is in second decade. Starts usually on the upper body. Mucosal sites are involved, as I've previously mentioned. I'm slightly repeating because these are 2 topics, SGS and TN, and they are overlapping. So it's always better to sort of go through them once more. Nearly every patient will have ophthalmological involvement. Lymph nodes, hepatosplenomegaly, genital lesions are very normal, including PR and PV, and musculoskeletal involvement is also present. Labs, high ESR, leukocytosis, eosinophilia, anemia, that's what we have to look or watch out for. Unfortunately, neutropenia is a poor prognostic factor here. Prognosis, usually a few weeks course. mortality, some people, if this trapped in early, it's around 10%. Obviously, it's from another different paper where it was reported as 5%. So different parts of the world will have different access to the healthcare, and the earlier we step in, the better it is. Complications, obviously, one third, as we discussed. Uh, Again, this progress to severe end of the spectrum as well. And this is the international classification from 1993. I hope there is a new update. I will share the British Association of Dermatology guideline soon, and you will on the screen, and you can see. Yeah, it's a fantastic document published by the British Association of Dermatology after a lot of hard work. I will encourage most of the participants here to at least read it, once, and keep a copy with yourself, because it's freely available on internet, and it summarizes most of the things we have to do as a clinician. And with regards to the management, you can see, as we were talking about eye management, mouth, or mucous membrane management, nutritional support, psychological support. Don't forget, because I've come across that patient who ultimately sued our trust with regards to the post-traumatic stress disorder. 16-year-old. Now, obviously, he's in early 20s. So what we have to do, management, we have to say acute management, immediate, and then midterm, and then long term. And then think about it. Obviously, acute management is managing the emergency there and then, while on the other hand, more midterm and long-term managements are for the complications. Now, this is British dermatology guidelines available freely on internet, and quite a few papers, and they have summarized this for us. These are the typical areas involved in SCS and TN in children, and these guidelines are specific for children, and you can see the difference between adult and children. You can see here, high risk group, the ages are different, etiology, more of infection in adults and more of medications, more of in adults, and infections are more in children. Prognosis, mortality is on the both ends is significant. To me, any infectious disease or any cause which can be treated in the current advanced medical practice, even one is too much. So mortality, from my perspective, is significant, because mortality shouldn't be happening if things are treatable in current scenarios. Again, differentials are slightly different as well, but recurrence in adults it's less likely, but in children it can happen because of the infectious agent. Again, our differentials, we have discussed that previously as well. A few more here, including Behçet's, pemphigus vulgaris, and obviously linear IgA disease. If you're seeing a patient post-transplant. Medications we've also talked about, more of antibiotics and anti-epileptics, and then anything else, but less likely as compared to these two. Now, complications for the eye. The reason I'm putting it out here, because we don't want to miss something we can easily treat. That's the fundamental principle. But here, ophthalmology, eye, we have to involve ophthalmologist immediately, as soon as possible. You can see quite a bit of complications. This is again from British Association of Dermatology's guideline, and these are treatable. Otherwise, the problem is the child's corneal haze will develop a very poor vision for the young one. Pathway for the care in young people, again from British Association of Dermatology, you can see quite well written and very methodical. So please do at least print it out, or put it in a bigger poster and put it in your department, especially the frontline staff, emergency department, or accident and emergency or casualty. General management we talked about as with regards to this condition. Again, a little bit of recoup. It's the skin care, mouth care, fluid management, eye care, nutrition, analgesia. So these are the different boxes we have to think about, and then obviously take it further according to the needs of the patient. And you can see less than 10%, more than 10%, and that's the differential. That's the cutoff for the diagnosis, and then obviously we can follow as discussed this pathway of the care. Coming to the last topic now, Staphylococcal scarlet skin syndrome is potential life-threatening. Obviously, these are dermatological emergencies, toxin-mediated, secondary to localized skin infection, disease of young people, under 10, mostly. And most of us here will think about antisepsis or clearing the skin, but do consider that chlorhexidine hand washing may not be sufficient. We need to go beyond that. This is a toxin rather than a pathogen. And you can see the exfoliative toxin of the Staphylococcus aureus in the epidermis. Mostly this starts around the face and then upper chest and then move on and involves the rest of the skin. Age up to 6, but up to 10 is reported. And fever and reddening around the mouth, more common around the eyes as well. You can see on the photograph, Nikolsky sign is positive as the peeling of the skin because of the fragility of the skin. Extremely rare in adults, so it's very rarely reported. And you can see the wrinkling, fissuring around the mouth, eye discharge. So infection, and infection in the form of toxin actually is the cause. Clinical features, skin at normal sites also exfoliates easily. Again, this is obviously the Nikolsky sign. Sharp pain. So the child is in pain. So please do consider pain relief whenever you see a child in agony or generalized skin involvement. Mucous membrane usually is not affected, and scalp is less involved, but can be. So it's rare, but it's reported. And usually heals as soon as the antibiotic is started, and the healing is as exfoliation happens, and the entire course of the treatment is up to 2 weeks. As we have also already discussed, nasopharynx, conjunctiva, so upper respiratory tract involvement, and then with the circulation, it spreads to the whole body, and the diagnosis is clinical, but skin swabs will help. Blood culture and skin biopsy in rare cases. So if you remember in TEN, SJS, we have shared a slide previously where there was histological demarcation, so it can easily be picked up from histology. But again, we have to think about it clinically, skin swab, blood culture, and then the biopsy if needed, if there is diagnostic uncertainty. Characteristic faces, and that's the reason I've shared the photograph along with the Nikolsky sign. It looks like most of the people are described as burnt skin, but with the normal oral mucosa. That's the difference between SJS, TN, and here. Drug-induced, well, that's the TN again. So this is the differential. So if there is a drug pathology or drug involvement, then usually it is TN. TN is rare in infants, so that's another differential. This is more in young children. And bullous impetigo can mimic this. So do think outside the box, but they don't have any characteristic faces like this one. And Nikolsky sign is negative in bullous impetigo. Treatment, eradicate staph, so obviously IV antibiotics. Oral antibiotics have systemically well, but I would probably say if you are giving someone oral antibiotics for this, you need to monitor them every few days, or they should have open access to the ward. With the obviously red flag signs discussed and documented. Supportive skin care, fluids, electrolytes are admitted, and mifepristone for nasal eradication. So this is obviously the common practice points. You can see here on the photograph projected here, sort of erythema, perioral involvement. That's where it starts, and for the first 10 days, you can see as it progresses, perioral fissuring, milia-like vesicles, and then the scales as well as lamellar scales on the extremities. And temperature, you can see for after the first week is usually is managed and it comes down, and it's more common. It's usually good prognosis, but what happens is more common complications in patients who are immunosuppressed or they are very young, like infants. And key points for Staphylococcal scarlet skin syndrome. One, obviously, there are no long-term issues with the skin. It's not like TN, SGS, where one-third will have intraepidermal blistering, that is Nichols sign positive, and it's a spectrum of disease. Bullous impetigo is labeled or comes under this umbrella term as well. And the flaccid blisters, erosion immediately as soon as it starts, because of the flaccidity of the blisters. Nichols is positive, and intraoral or any mucous membrane involvement is rare. With that, I think we have come to the end of the presentation. Apologies if I have to rush through, and there were some technological issues today as well. This is the last of the 6 webinar series. As the normal practice of my presentations, I will share another important or something significant in our history with you. This is Fez, Morocco, and why it is important, especially in Islamic history. You can see fantastic place. So this is the place which I visited, and the reason, one of the reasons or attractions is this Islamic mosque, which was the first by anyone. But remember that this university was started by a Islamic or a Muslim lady in the mosque. And the fantastic thing was this university was still operational up until 2012. And our history is fantastic, but you can see longest serving Muslim university started by Muslim women. So people, if somebody tell you that ladies are not very much empowered in different religions, don't listen to people. Do think and read yourself. Go and see, watch, read about the history. And we are all about empowering not only men and women, but everyone in the society, because society is made by the people. So with that, I will probably say thank you very much to all of you who have joined us repeatedly for these presentations. This is one of the hospitals I recently worked for, St. Mary's Hospital. Again, I was very much privileged, and I felt proud working there, because across the street from my office, this was Sir Alexander Fleming's laboratory, where the penicillin was discovered. So life takes you from through ups and downs, but do remember there is a life outside medicine for all of us, and medicine was built upon the experiences, life experiences of in the history by the other people. And with that, I will say a huge thank you to Download Amjad, Google Images, and all the educational material from the Google Scholar I've used during this educational activity. And let me see if there are any questions which I can answer today. Now, the first thing is, well, apologies, I'm unable to hear. Somebody has written down initially, but again, that was IT issue. With regards to the antihistamines, how many days? It's usually for a week, 5 to 7 days. And I think that's the only question asked today. And there are a lot of complaints about the sound echoing and the IT, and I can only apologize for that. There was a power outage here, and we are running on a remote device at the moment. So I hope you all will forgive us for that, and hopefully we'll get in touch again and with our next presentations, hopefully soon. So with that, thank you very much, and do enjoy your day and your weekend, and inshallah, we'll see you again soon.